Hello, everybody. I want to thank very much Professor Panayotov and Professor Papatanasiou for the very kind invitation. It's a great pleasure for me to be here in Bulgaria as the northern neighbor of Bulgaria. I saw the very positive presentations of Professor Imamura and Professor Foti. I will start my presentation with not such a very positive vibration, let's say, but I hope that this is for us to stimulate us and not to be a barrier. So I will try to do a SWOT analysis of our specialty. And this idea came because in Romania, in the last 2 years mainly, but the whole period of me being specialist in Romania, I had some a feeling of uncomfortable and of our specialty not being recognized at the real value that it brings to the person. Also, my experience with the European Union of Medical Specialists since quite a long time. I think I first joined the UMS PRM in 2001 in Pavia. So, Calogero for sure remembers, organized by Alessandro Giustini. Anyway, I think I can share with you my views on this idea, on the strengths and the weaknesses and the opportunities and the threats that are challenged to our specialty. So if you look at strengths and weaknesses, you may recognize that these are internal characteristics of our specialty. Otherwise, opportunities and threats are external from our specialty, but of course they can influence them. So both the internal and the external, we may have means to influence them. I will start with the weaknesses and threats just to end on a more positive note. We must influence the internal weaknesses of our specialty. How to do that is very specific to each country. But I think there are some common traits for the whole region of Europe and for the whole world. What I see as weaknesses, I think our specialty is insufficiently recognized, first of all, to political decision makers, but also, let's face it, also to our colleagues having other specialties. They really don't understand, and they put the question, hey, what are you really treating? Is it just the physical exercise done by the physiotherapist? What is it? What is the identity of our specialty? Is it balneology, like we developed more in the Central and Southern Europe? We had, during the communist period, a long tradition of development of balneology, which then changed to rehabilitation. Why do we have those two names put together, physical medicine and rehabilitation medicine? What's the difference? I think most of the specialists in other specialties, and for sure political decision makers, don't really understand our specialty. Our specialty is quite peculiar in the range of medical specialties because it doesn't treat one single organ or one system. But you can look at this as a weakness, but you can look at it also as a strength. And I think it's more a strength than a weakness. Then we have, from my point of view, we have an unevenness of training between centers, between countries, but also within the same country. I think that we should develop a common language and not use different terms in different centers within the same country and different terms within different countries. I know this is not easy. I know some translations are very difficult to be made, but I think that our international and European societies and other bodies that deal with our specialty should focus on having to develop a common language that is adaptable to each country. A lot of other specialties say that we don't have guidelines. If you look at cardiology, if you look at many other specialties, gastroenterology, rheumatology, they have very clearly defined guidelines that are Europe-wide, some are worldwide. I don't see those very clear guidelines in our specialty, and I think there is a very clear reason for that. And it's not a negative reason. I think it's a positive reason, but we should learn how to exploit this in a positive way. But we have the position papers, at least in Europe, developed by the UMS. Look from the presentation of Professor Foti, the arguments, the evidence-based medicine for vibration. It's a very hard work to do evidence-based medicine in physical agents and in rehabilitation also. This is a weakness because all our colleagues are accustomed, they have a pharmacological substance, they know exactly the mechanism where it works, and because of this, they conclude that it will bring this and this effect, which is partially true, because if you target with a physical agent one mechanism, you disregard the millions of other mechanisms in the body. And with the, I think, my opinion is that with the evidence-based medicine that we apply right now, this is quite a limiting factor. If we speak of physical agents in general, from vibration to heat, to laser, to ultrasound, to everything what you want, it's very difficult to do an evidence-based study according to the rules that are applied to pharmacological agents. That doesn't mean that our agents don't work. And if we talk about natural therapeutic factors applied in balneology, then the situation gets more complicated. So it is clear that our specialty deals with mainly two key terms. One is disability, the other is functioning. If you look at the definition of disability in the World Report on Disability, disability is an interaction between the person and the environment. It's difficult to measure an interaction because if you look at the principles of quantum physics, the simple fact that I am observing a process brings changes to the process. So disability being defined as an interaction, it's very difficult to measure. Then, like I said, why do we have these two terms put together? Physical medicine, rehabilitation medicine. All these need explanations to our colleagues and especially to political decision makers. But I think the WHO and Professor Imamura has shown the huge steps that have been done in understanding the process of rehabilitation in general and rehabilitation medicine in particular. I know, a lot of weaknesses, another slide with weaknesses. So, like I said, it's difficult to measure the effect of physical agents because, as Professor Foti has stated, this is vibration. Look at what Tesla has said, energy, frequency, vibration. We are not used to measure these things. We are used to measure just chemicals, material things. But energy, vibration, and frequency is much more difficult to measure. And it's not in our custom to measure this. I think that actually all the physical agents produce an energy transfer to the system, to our body. And this is the effect, the positive effect that it exerts on our body. I'm a big fan of Star Trek, so if you remember the tricorder X, it came to the person with an injury, then it analyzed the frequencies that put some parameters in there and then put the frequency that was lacking in the body, and then the patient was healthy again. Balneology is a part of the physical medicine. They are physical agents, but they are natural physical agents. Look at the northern part of Europe. They contest balneology very strongly. But we in the central and southern part, we know that it works since hundreds of years. Not like a pharmacologic agent which changes every 5 or 6 years because something new comes. Our agents work since hundreds of years. And I think there is, unfortunately, a lack of professional unity, at least in my country. And I think this comes because of lack of understanding of our specialty. What are the threats? Threats are external to our specialty. I think we can influence them, but we have to have a professional unity to influence them. We had in Romania, we had in the last 2 years, 2 very strong examples of external threats. The first one is an order from our Ministry of Health, done by a lot of political and the specialty pressure, in which a quite significant amount of money was sent to a specialty that didn't have formation in rehabilitation. I can be more precise. There was an order for the first 72 hours after a stroke, and neurology and neurological departments received quite important amount of money in Romania. But what was that money for? It was for tablets for psychological assessment. It was for elastic bands for training. It was for treadmills and things that no one who had 6 years of medical training would apply in the first 72 hours after a stroke. But this is politics. We then had another very strong example which put a very high pressure on our specialty. Some political decision makers thought there could be a sign of equal between physical and rehabilitation medicine and physiotherapy. This was a 2-year struggle. When I say lack of professional unity, I'm thinking more of to have a common voice to political decision maker. And we know that political decision can influence strongly every aspect of our life. We know that a lot of other specialties do rehabilitation without having in their curriculum rehabilitation. And I think that the concept that rehabilitation is limited only to physical exercise done by the physiotherapist is one of the motives that other specialties think that rehabilitation equals physical therapeutic exercise. And on one hand, I think that it's also our fault that we couldn't transmit the real object of study and of treatment of rehabilitation medicine. What we see, what I see, and not only me, is that in general, at least in Europe, there is a tendency to go to health professionals that pose a smaller cost on the health system than medical doctors. And I think it's the case of nurses and physiotherapists that are stimulated to do many, many more interventions that actually, in my opinion, should not be in their domain of work. I'm turning positive now. I go to strengths. Of course, strengths are internal, and we are the ones who have the means, who can influence them. Like I said before, not dealing with a single organ, I think, is one of our strengths. But at least in Romania, I think that we were not able to transmit correctly this idea. What we see in Romania in the last 15 years, let's say 20 years, that PRM has become a most attractive specialty. We have each year between 70 and 80 residents that choose the specialty. Of course, if we look at the situation here with the Ministry of Health, with an emergency ordinance that put an equal sign between physiotherapists and PRM specialists, this created a problem, and we saw a reduction of medical students who choose residency of PRM. I think our specialty is very, very complex. We have means of intervention that are very, very diverse. If we look only on injections, if we look on EMG, if we look on repetitive magnetic stimulation, if we look only one of the small things that are included in our specialty, it shows how diverse and how offering our specialty is. And of course, I think the patients are our publicity, and after coming to rehabilitation, at least in Romania, we see, why didn't anyone tell me that I should do rehabilitation after a stroke or a spinal cord injury? Why didn't I knew that? Another strength is what Marta has shown is the international documents, the ICF, with the corsets for different health conditions, the World Report on Disability, the Convention on the Right of Persons with Disability. European and international bodies are very active, and you can see some of them. And I'm sure you know that there is now an action to put together another European body, UniPRM, that would include academics and researchers, exactly for the motive that Professor Imamura has shown in her presentation, to boost the development and the research in our specialty. The fact that functioning is so important is shown that in the ICD-11, in the last International Classification of Disease, you have a small, but you have a chapter of functioning. And in our discussions with people from the WHO Europe in Denmark, their vision is that functioning will be in the future more important than the diagnostic of the health condition. We have in Romania this agency, this government agency under the Ministry of Labor who deals with persons with disability. Not very active and efficient, unfortunately, but it exists. I think another strength of our specialty is that includes in the rehabilitation team other health professionals. And this shows the openness and the complexity of our specialty. The fact that functioning is the third health indicator at the WHO and that disability is a health strategy shows how important rehabilitation in general is. But I think we do not do enough to take advantage, at least in my country, to take advantage of all these strengths. About opportunities, which are of course external, and how we can influence them. As Professor Imamura has shown, 1 in 3 people, 1/3 of the global population has a disability, needs rehabilitation. Of course, we should recognize that it's also mental disability, that it's also sensorial disability, hearing, vision, and so on. But anyway, 1/3 of the global population needs rehabilitation, not only neuromusculoskeletal, the main things that we are dealing in this Congress. Then there is this action, Rehabilitation 2030, and the World Rehabilitation Alliance, which is very important for promoting rehabilitation in general. But I also think that we should make a step further and look at how social media and influencers can boost and facilitate the understanding of our specialty, not mainly for medical doctors, but I'm looking at political decision makers who, in my experience, and I think in all our experience, can have an extremely important role to decide what is important. In conclusion, I think that our specialty is a honey jar, and it depends only on us how we shape the future of our specialty. Thank you very much. Thank you.